Thank you all for joining us today for our first video conference learning cluster on utilizing peer workers. We have Christine Ullstrup, Rachel Fox, and Jennifer Lewis here with us today. We really want this to be an interactive learning cluster. So I'm going to very briefly have our three presenters introduce themselves and speak just a bit about how they use peers in their AIA project. And then we're going to open it up for some discussion. Folks had emailed in some questions that they had about using peers, and it looks like overall people are really interested in experiencing, learning from others' experiences of common pitfalls in using peers. I believe we had 11 grantees who signed up for the cluster and who will be accessing this after if they're not on the call. Many of them do not have a system in place in their agency for utilizing peers at this point, but they're interested in starting one, and they want to know what to avoid. They want to hear about lessons learned, and they want to hear about innovative ways to utilize peers. So that will be guiding our conversation today. So Christine, if I can turn it over to you just for a brief introduction and to tell us a bit about how you use peers in your project, that would be great.
Sure. The name of our agency is Made a House, and we actually have three levels of care here. We have an outpatient, a residential, and a housing program. And we use peers at each one of those programs in different ways for different reasons. Our AIA project is working with women who are pregnant or postpartum in our outpatient level of care. And so that's where we really rely strongly on our peers in the way of engagement and retention is where we're emphasizing how they can help us. So what that means is that as we hear about women who are interested in getting into our program, sometimes getting to treatment the very first time might be something they're helping with. And then once they get to us, how do we keep them involved? So that's how we're using peers in this program under the AIA in a nutshell, but then I can speak more about peers in general as we go further.
Great, thank you. And just to reiterate, your peers actually engage and retain the clients, because I know some folks were interested in how to engage and retain peers. So we'll be talking about that in a bit.
Right, I was talking about engaging and retaining the clients, right?
Absolutely. Also, if folks have questions at any time, you'll see a little icon in the top left corner of your screen that says raise hand. Feel free to do that, and we will get to you just as soon as we can. So Rachel, your turn. Let's hear about how you guys use peers.
Well, I am the manager of the Early Childhood Division here at Arbor Circle in Grand Rapids, and the AIA project that we're involved in is the Mission In program. And Mission In is a project serving women with any history or current issues with SUD or, HIV/AIDS. But primarily, we serve women with substance use disorder issues. And the program offers an interdisciplinary team model. So there's a therapist on the team that's credentialed in SUD and also in infant mental health. And then we have a case manager, and she also does a lot of research coordination and data collection. And then we have a peer recovery coach on the team. So those three gals work together with the cases, and it's a very holistic and kind of a wraparound model. And so they're able to divide and conquer like the SUD, mental health, attachment issues, the case management, basic needs deficiencies, education resources and research components. And then the peer recovery coach really focuses on recovery, relapse prevention, takes clients out for respite to meetings, AA, NA meetings, and really offers a specialty niche on the team.
Do you have a requirement for how long peers need to be in recovery before working on your project?
We don't have a formal policy around that. Generally speaking, our agency has a lot of peers working. We have about 40 different programs, and a number of them utilize peers in different ways. We have some peers that are more community health workers. I have a program called the Baby Scholars Program that uses parents as peers to other parents. So there's a lot of peer work in general at Arbor Circle and in our community. With all of those different programs, generally speaking, we like to see folks in recovery or out of services for at least a year before we would actually consider employing them as a peer.
Great. Thank you. Jennifer, you're representing the HIV world on this learning cluster, so I'm curious to hear your perspective.
My name is Jennifer Lewis. I'm here on behalf of the University of California, San Diego Mother, Child, Adolescent HIV program. And our AIA project is called Families First, where we're providing HIV primary medical care, mental health, social services, parenting, and substance abuse, all in the context of HIV care. And we have a much limited role for our peers. These are all HIV positive women that are helping with engagement and retention and care.
Specifically, what does that look like?
So oftentimes for those of us who have been working in the HIV world, we're aware that engagement and retention is a key to prevention of HIV and prevention of transmission. And so we find that for some of our HIV positive families, there's a lot of hesitancy or resistance to working with professionals. And so we find that having a peer on our team, an integrated peer into our team, they're much more able to access individuals in the community and can take on a little bit of a different, less formal role. And it's been completely invaluable in terms of getting our families that are more hesitant or more anxious into care and then working with them around some of their concerns as they're in care.
Great, thank you. You know, one of the common challenges I hear is that it's hard to, for projects to retain peers. Have you struggled with actually retaining peers? And if so, do you have any lessons learned in maybe your recruitment of them? And this is open to all three.
Oh, I'm sorry.
Yeah, go for it, Rachel.
When I saw that comment on the questions that was submitted in, I was surprised to see that because at least in my experience and at our agency, that has not been the case. And when I reflected on why that may be, we do not see peers leaving our organization. We have a nice, they meet at least monthly as a group. There's a lot of support. It's very welcoming to them here, I would say. And so all of the peers throughout our agency meet at least monthly, and for supporting one another. We have a lot of staff development training around SUD and use of peers as an organization. So it's pretty ubiquitous through our organization, the culture of using peers. And I know that the peer recovery coach for Mission Inn is also connected with a community network of peers. So that might be the key thing for us that helps us to retain them. That came to mind when I read that question that's been submitted.
And I would say that we haven't had a problem with retention either. I think the people that have left, the women who have left that were our peers, one was a medical reason, the other was that she got back into a profession she had years ago and it really was her passion, and so she went back to that. I agree that I think part of it, what's good for retention is really supporting their role, making sure that they're a key member of the team and they sit in on team meetings, they get the same education and support as our clinicians do. They don't feel like they're less than or secondary to the clinicians or any of the more professional team. I think how you value them, is a strong reason that they stay. And the support and supervision.
we probably could have learned from Christine and Rachel. We struggled for sure. We actually have an open position right now because we have a peer that left. I think for HIV positive peers it's really challenging because when they're applying for positions they very much want to be part of the institution and the team, but being out in the community disclosing your status as your job is very, very challenging. Our most recent volunteer had a child who was also HIV positive and in, I believe, junior high or high school. And so she had a lot of angst around, being out in the world and in the community in a way that would also out her family. So it posed challenges that, I think we have lots of lessons learned by default, for sure.
Rachel, you had mentioned, and I'm sure that this is true for all three of you, but that your agency has trainings in place for SUD and peers.
Mm-hmm.
Are those kind of PowerPoint presentations, are they shareable with grantees, or is that more just a professional giving a talk?
I could check into that. We have a monthly staff development training opportunity that the agency hosts, and quite often there's like social work CEUs, and they do topics that are helpful to the work that we do. And I know that we've done a lot on trauma and substance abuse and peers. I believe so usually we have a facilitator and then either some clients or a peer recovery coach speak and take part in that. But there probably is, I can recall some really good PowerPoint presentations too, so I could check into that.
That would be great, thank you.
I don't know what the other states do, but here in Wisconsin, our peers get certified.
Oh.
Do you guys are you peers certified by the state or licensed by the state in any way?
Yeah, our Kent County Community Mental Health Organization credentials and certifies peers, and they offer that quite regularly. It's quite rigorous, but the folks that come to work at our agency have all been through that.
I would imagine that does lead to better retention.
For us, I think, we will hire somebody before they're certified because sometimes our graduates or people who want to be peers don't even know about the fact that there is this license or that the state has headed in this direction. And so we will hire them on, but then we require that they attend the training. And the training really, I think, gives them a lot of valuable information so they feel better prepared. And, it's recovery from SUDs, it's recovery in mental health, a lot on boundaries and ethical decision making. They get exposed to motivational interviewing, the stages of change. And so I think it's a really good foundation. And I think it's 40 or 45 hours that they need to do, and then there's a test. And then they do get certified. And at some point in this state, there'll be some billing mechanisms through Medicaid, perhaps. It's not quite yet happening in Wisconsin that way.
It's very similar to Michigan, and there's been a lot of talk in the last few years about being able to bill for peers here as well.
And are those specific to recovery coach peers? Do they have to have a history of substance use? Is that the peer training program you're referring to?
Here in Wisconsin, they've actually, they have two of them. Actually 3 tracks. You could go down a substance abuse track, a mental health track, or a dual track. And so depending on your lived experience, where you would go, but you have to have the lived experience.
What was that third track? I'm sorry, you cut out just a bit.
Dual. So substance abuse, mental health, or dual together.
Sure. Great. So let's talk a bit about supervision, the structure and the support that's provided to peers. What does that look like in your agency? Is that similar to other staff members' supervision structure, or does it look different for peers? Anybody can jump in.
Well, for the peers in my programs, it's similar to other staff. They typically have weekly or bi-monthly one-on-one supervision. We also offer in my division reflective supervision once a month for about 3 hours, which is a component of infant mental health where the focus is more on how the work with families is impacting and affecting the therapists and the peer recovery coaches. So that's a little bit more. And then, so it's fairly similar to what we offer to the rest of my staff, and I have a number of bachelor's level, but primarily master's level staff doing therapy, case management, education.
Our peer specialists here we've noticed over the years that we really need to have intensive supervision, and it's important. It's really important. And so one of our master level clinicians does the supervision with the peers, and they get individual and they get group supervision, and they attend the weekly staff meetings, and then sometimes, which helps too. And I was really interested in that you're doing reflective supervision. We're not there yet, but it's something we're checking out. And it came to us too because we've got 2 people here doing infant mental health.
Yeah, the staff really value that. It's hard to add another 3 hours of meetings on top of everything else they have to do. But I've really found that for the level of trauma and stress and when you're considering like secondary trauma and burnout and sick days, it's been worth it for my programs. So
I would be interested in offline or maybe another session on how you started that and what you did. We're starting. They're doing it at our child welfare agency, local agencies, and so we're starting to partner with them on some training, but we're very little into it right now, barely into it.
Jennifer, what about you guys?
We offered individual supervision. We only had one peer peer at a time, so it's very, very small. But we would offer individual supervision, and I can certainly share some of the challenges associated or some of the content in supervision for those agencies that are just considering embarking on this. We found a lot of struggle for the employee around how to communicate their role, their unique role out in the community, because I think the tendency for the clients to connect with them as a peer is what we were hoping for, but at the same time they're not a peer and they're not a friend, and sometimes that changes their relationship had they had a prior one, and in other cases it's a little confusing. I think it's confusing for the client. It's also confusing in some cases for the peer, the employee. And so I appreciate that the supervision is supports people around boundaries, but helps them to navigate that tricky road.
Sure.
Yeah, I think, and many of our peers are graduates of our program, so, they had one experience when you're here as a client and receiving services, and then you come back in. And so really helping them, I think, in the supervision really helps kind of navigate what that's like, the changes that they have, what that relationship is. I think that even the most seasoned clinician at times struggles with boundaries or counter transfers, etc. And so I really think that, especially in the beginning when they first start, intensive supervision is really needed, just to keep an eye on things and that they have a place to talk about what's going on.
So to the programs who are starting up and ready and excited to use peers, what words of wisdom would you give them? What would you caution them against? What would you guide them towards? What are your nuggets?
Well, I really have seen that being connected with a network of peers whether the focus is on SUD or mental health or parenting, or we have like a lot of community health workers in our community too that focus on more physical health issues. But in all those different arenas, I've seen that the individuals will really have a nice supportive network. And so I would think that if we were kind of starting out, getting new peers connected to that network for some mentoring, professional development, that unique support that they can really only get from each other might be really helpful. That's one thing that comes to mind for me.
I think we've made, you asked in the beginning how long somebody needs to be in recovery, and we say 2 years in recovery. And we I think learned that over time, even with some of our staff roles, that we think that 2 years of recovery kind of gives you a good cushion, and you're perhaps a little healthier. I'm not saying that one couldn't do it sooner, but that's what we've learned, that 2 years is kind of a good benchmark for when you would hire somebody on as a peer. The other thing I think we learned just as we interview people is that I think it's important that peers are able to either express or be open to learning more about that everybody recovers in different ways. We haven't had this experience that we've hired someone, but I've heard that, in interviews and from coworkers at other agencies, that sometimes people in recovery might think that there's only one way to recovery, and that the way they got well is the way that works for everyone. And so you need somebody, I think one of the key things as you're in the interview process, as I said, is looking for openness, looking for a person who wants to learn more on an ongoing basis.
I think for us, when you're working in a medical team, there's already enough challenges around hierarchy. And so I think doing some prep work beforehand and making sure that whether it's the medical providers or the social workers or whomever they are understand that this is a team member, just like any other team member, and that they need to be included on decisions, discussions, very, sort of highly respected for their piece of it, so that they don't get sort of excluded from components that where other people don't deem them to be necessary, because I think that can be very destructive very quickly in terms of communicating to somebody who's probably already feeling insecure that they're, measuring up to the level of a physician, or even somebody who was their physician at one time, that they are a critical component to the team. So I think that the prep work prior is very, very important. Lessons learned.
Erin,
yeah, I agree
Regina,
that. I think it took us a while to have all the staff understand the role of a peer and what their role is, and as you said, a key member of the team. And if you have new staff coming in, to keep everybody understanding everybody's role and having really clear job descriptions, and that everybody understands everybody's job description, because they're all important, but they all are a little different.
Mm-hmm. Absolutely.
And I've seen that too, helping identify their unique role and focusing on healthy boundaries, both with the team and with clients, as being very helpful to have a healthy, functioning, program. I think that one trend I've seen with peers is that because they're so effective at outreach and recruitment and retention, and they're relatable and engaging, it's fantastic. As I did social work in the field for 10 years and had some community health worker peer partners, and they would get me into every home, and I literally in 10 years did not have one family that wouldn't work with me, even though I was a social worker, and there's a lot of stigma there, because they were like my mental health ambassador to get me in the door, and it was just wonderful. But one thing I did learn, and now as a manager I see this, that because the clients connect so deeply with the peers, there can be this trend of, well, why do I need a therapist? I have you. Why do I need a case manager? I have you. And and that can put a lot of pressure on the peer and just unreasonable expectations, and even create some tension on the team too, that the client may be sharing a lot more with their peer recovery coach and they're not disclosing the stuff to their therapist. So we've really focused on healthy boundaries just all around in training new staff, and then just kind of ongoing to keep things balanced and functional with our program.
Jennifer, I saw you nodding. It sounds like you have similar experience.
Yeah, no, I think that's great, very, very important advice, because I do think we too struggled around, the peer having such great rapport and relationships with the clients that they were being asked to hold information from a peer perspective that, I think sometimes the clinicians didn't know, and I think in our case the peer felt really conflicted. This information was shared with me, and it's because of the peer that it was shared with me, and if they wanted their clinician to know about it, their mental health clinician or their social worker to know about it, they would have told them. And so it's hard, it's a very unique position, and I think the more support that they have to know that they're a critical member of that team, and that we don't, we all work interdisciplinary, sort of we don't hold secrets, that's really important. And again, I think, just to reiterate, I think it's a confusing relationship where, most of our clients understand the role of a mental health professional or a social worker or an administrator, but when you add somebody that is a peer, sometimes it's confusing for them. So it's more helpful, I think, if it's clearly defined.
To wrap it up, I was curious, you had talked about this issue of peers working with a client and the client disclosing information to the peers, that then the peer is in a position of, do I share, do I not share? What is the protocol in your office about that interdisciplinary team and confidentiality and what is shared, what is not shared? Are there protocols about that?
I was going to say, I think Jennifer said, we don't keep, team members know everything. So if you tell me something, your team's going to know it. But you have to make sure the client understands that as well. Right. And so oftentimes, and especially in a residential setting, which isn't exactly where this grant is, but our other setting is, they will go to like the 24-hour staff in the middle of the night or, those early morning hours and say, I want to tell you something, but you can't tell anything. And everybody here is trained to say, I hope you feel comfortable telling me, but just I want you to know that I need to tell your team as well. And sometimes it's nothing, sometimes it's not even something of consequence or but that always has to be communicated to the client, and then all the team members have to abide by that as well.
Makes sense.
We don't necessarily have protocols. I will say that I've supervised teams that are less functional than others. I'm thankful that my mission in team right now is very supportive. They have healthy communication, good boundaries. They kind of stay in their lane but support each other. But I've also supervised teams where that hasn't been the case, and it's been much more conflict and more challenging. But the team meets weekly to talk about cases and make a plan. They're all on the same page. They support each other. They kind of hold the line with issues with clients. So I think just creating an environment where open and honest professional communication is ongoing has helped for Mission N.
Great.
We haven't had protocols, which is some of our challenge, but I think, there's lessons learned. Some of the other areas, if I could just sort of ask the group this because of the expertise, one of the other challenges we had is when our peer wasn't doing well. So personally, where we learned that they weren't caring for themselves, or that they were, we learned sort of along the way that our peer wasn't in HIV care and wasn't taking medicine, and So here we had this individual in a role of really helping with medication adherence and HIV care, and she wasn't able to navigate that herself. And I think that while we sort of jumped in, or I jumped in as a supervisor to try to help her, it felt different from any other way I had supervised employees before. And so it for a supervisor, that too is different. Where I would normally refer somebody to EAP, do I instead jump into a case management role because it's around HIV? So it's just, I think we found ourselves in uncharted territory. I'd be interested to hear how other people navigated that.
That's a very interesting point. I'm glad you brought that up because, and here's, I think, the second layer of that is, so I'm a person in long-term recovery myself. And so when I did some of the peer supervision, then you're also coming from your own, you're a peer to them, you're their supervisor, you understand recovery maybe in a different way as well. So I think that you're right. As a supervisor with some of our non-peers, you might not get into all those issues, but as a supervisor, it's a little bit different of a role because they need to be the model, right? So the supervision to me goes around, you need to be modeling this behavior. Part of the job description says you part of your role is to model recovery and to be healthy in your recovery. And so if you're not doing what you need to do, you're not modeling that anymore, and you're not fulfilling your requirements of the job description. So, I mean, you can keep it professional on that level, but then you want to be helpful too. And so it's a balance, right? It's a balance.
Yeah, thank you.
Do you find yourself being helpful, Christine, or do you generally refer them elsewhere?
I think we try to do things in-house as much as we can without going to an EAP. Obviously, they're all, not obviously, but they are, most of them have their insurance with us. They're eligible for EAP services. But I think some of the things they're struggling with are EAPs aren't always able to help, or this is an expertise of what we really do, And we'll throw in the layer that they used to be our clients. And so some of us might have had them as they might have been on our caseload. I have that with my supervisor now. She's supervising some people in a new role as their peer role, and she was their clinician at one point. So she knows some of the things about them too, and how do you ride that fine tightrope kind of thing of being their supervisor, not their clinician anymore, but still being helpful to them because you kind of know what they need.
Rachel, what has been your experience?
Well, the direct supervisors over the programs are experienced. They're SUD certified themselves. They've been out in the field. So, and we really have quite an open door policy around supervision in my division. So I feel as though the folks doing the peer work feel, supported, and they can come and talk, and someone can identify and relate to maybe what they're going through. Generally, we have them seek more support outside of our organization as needed. But I'm just, as you're talking, thinking about an issue that came up recently. We're seeing a lot of families with the medical marijuana cards now. It's like everywhere. And so issues like that are challenging and complex anyway, for a peer in recovery to go into homes where now they have a prescription to smoke marijuana. It's so complicated for them. And one of our peers, it was a trigger and it was challenging. So they, that was brought to our attention, and she just needed some additional support and some planning around how to still serve the families but not put her own recovery at risk, So, yeah, again, I think our culture has been responsive and supportive. It's not necessarily like policies or procedures or anything like that.
Great. Well, thank you, all of you, for being here today. Like I mentioned, we're going to make this available on our website to the folks who weren't able to log on. If you have any resources that you feel comfortable sharing with us, we can post those as well. Let us know if you're comfortable having them seen by the general public or if you'd prefer them to just stay AIA grantee specific. And you can email them directly to me, and I'll make sure that they are posted.